Hello. So welcome and thank you all for attending the webinar on narrowing the Black-White Health Gap, opportunities for private investment to drive progress in the United States. My name is Nzinga Broussard, and I'm a senior manager at New Market Support Company. We are happy to be co-hosting this event with Rhia Ventures. So before we get started, just a little bit of housekeeping. As you see, this webinar is being recorded, and a recording of the webinar will be provided to all registrants in a follow-up email. We know that you all are going to have some questions, and we ask that you use the Q&A box to drop your questions in. Do not use the chat box. We will be monitoring the Q&A box, and during the Q&A at the end of the panel discussion, we will pull the questions from there. We will be using the chat box to drop in links to websites and resources that are mentioned during the panel discussion and from our panelists. And finally, if you're experiencing any technical trouble, try logging out of Zoom and logging back in, check your internet connection, and try joining from a different browser. As I said, thank you and welcome for attending. As you'll hear shortly, at NMSC, one of our impact mandates is to make investments that contributes to equitable health access to healthcare for all. In order for us to be successful in accomplishing that goal, we needed to better understand the constraints to health equity. That exercise resulted in the paper that motivates this webinar. In the paper, we did a deep dive into the root causes of the Black-White health gap and identified ways that we and the broader impact investing community could make progress towards narrowing that Black-White health gap and make progress towards health equity. And so for this panel, we've brought together health equity experts and investors to discuss this challenge and what those of us interested in pursuing health equity can do. So before I hand things over to our moderator and the panel, I first want us to see the Black-White health gap in numbers. So Black Americans have almost 6 years shorter life expectancy than white Americans. Maternal mortality rates are 3 times higher for Black women than for white women. Black Americans have higher rates of diabetes, hypertension, and obesity. So what is going on? Hopefully our panelists can help us understand why these gaps exist and what we can do about it. I would now like to hand things over to our moderator, Crystal Tyler, Chief Health Officer at Rhia Ventures.
Thanks so much, Nzinga, and welcome everyone. We're very excited to have you all here. I am thrilled to introduce our speakers or have our speakers introduce themselves. Nzinga, can you please go to the next slide? All right, first up, we have Donna from NMSC.
Hi, everybody. Donna Nucio. Thank you, Nzinga, for getting this started. Thank you, Crystal, for introducing us. So I just want to take a step back and introduce NMSC to all of you. So NMSC is an impact investor and fund service provider, which means our job is to boost the capacity of investors to identify, structure, and deploy funds into projects that address the racial health, wealth, and opportunity gaps. So we manage or administer over 100 funds, and it's notable that when we try to do this, we believe it's important to understand the challenges we aim to address, and I think this paper is a great example of that approach. We are an affiliate of LISC, Local Initiative Support Corporation. We were founded back in 2004 for the purpose of managing its new market tax credit allocation, and we've grown in a number of ways since then to support a variety of investors in the new market space and beyond. Our impact mandates, which Nzinga mentioned earlier, are listed here around quality jobs, wealth creation, healthcare access, and racial equity. And you'll see that they're aligned with today's discussion, but mostly I'm also excited here to be here today to learn from our panelists. Thank you.
Thanks, Donna. Now I will turn it over to Erica Seth Davies from Rhia Ventures.
Thank you, Crystal, and thank you everyone for being here. I'm Erica Seth Davies, she, her pronouns, and I am the CEO of Rhia Ventures. Excuse me, and at Rhia, our vision is that we see a world where every a woman and birthing person can thrive with full autonomy over their reproductive and maternal health. And we do that, or we strive to that vision by actually very intentionally leveraging capital in a way that will center the needs and experiences and perspectives of historically marginalized people in decision making. We do that through a number of core strategies that are integral to our theory of change, including venture capital investing through our subsidiary RH Capital, which is a traditional venture fund, making investments in early and growth stage companies with the potential to transform that market. We do this through ecosystem building in a way that's supporting entrepreneurs and investors and other players in the ecosystem, that they build and grow and invest in a way that's incorporating equity into decision-making, into product development, into governance, so that we're actually thinking much more intentionally about how do we get that innovation to those who are most in need. We do this also through corporate engagement and shareholder advocacy. So providing some of the recommendations on policy and practice that's going to advance reproductive and maternal health in the workplace, but also thinking intentionally about the ways that investors can leverage their role as owners of capital and shareholders to push companies towards reproductive rights within their policies, but also in their political spending. We're always thinking intentionally about narrative change so that we are lifting and centering the lives, the experiences, and the perspectives of those who've been historically marginalized, and that we're challenging some of the more harmful narratives that have allowed so much of the disparity that we'll talk about later on in the webinar to actually deepen. And finally, we are always willing to partner with ecosystem actors to make sure that we are supporting not only the measurement and the management and the intentionality with respect to equity to build the field and accelerate that growth in the field. So very happy to be here and looking forward to the discussion.
Thanks, Erica. All right, I'll turn it over to Barina.
Hi, I'm Barina Doggett. I am the Executive Vice President of Healthcare and Emergency Services and Chief Clinical Officer with So Others Might Eat, also SOME. We are a care provider in the District of Columbia. We have been working to break the cycle of poverty and homelessness through our whole person care model for over 50 years here in the district. And as part of that, we are an organization that works to make sure that not only is our healthcare models delivered in an equitable fashion, but along with whole person care, we understand that all of the pieces of what makes up an individual are vital to an individual's healthcare. So we look at all the social determinants of health, and we understand at a very basic level that housing is healthcare. And so we provide everything from emergency services, food services, dignity kits, showers, to a continuum of housing that involves short-term, transitional, supportive housing, long-term housing, and a model to help support home ownership for those clients in our continuum. So we work to help bridge that gap from the minute someone walks in our door and really look at how do we not only make change on an individual level, but how do we start changing the system in which we operate and the communities in which we operate, so that we can provide more healthcare, more access to services, but also change the environment in which we live. Looking forward to it. Thank you guys for inviting me.
Thanks, Farina. And then finally, we have Tiffany Green.
Hi, thank you so much for having me. As the slide says, I am currently Associate Professor of Population Health Sciences and Obstetrics and Gynecology at UW-Madison. Of course, I'm here representing myself and not the university. Most relevant to today's talk is that I serve as co-chair of the Black Maternal and Child Health Alliance of Dane County. And that is particularly salient to this conversation because this group was formed in response to the fact that at one time, Wisconsin had the highest Black infant mortality rates in the country. That is no longer true, but those rates are still quite high. We're in the top 6, right? And so this coalition is really trying to make change and is part of a larger strategy, a partnership with the Dane County Health Council and the Foundation for Black Women's Wellness and Equity by Design to actually change systems And that partnership, ConnectRx, which I'll be talking a little bit more about today, is one of those such efforts where there has been a relationship between private partnerships and communities, and I think is a really important part of this equation. At the end of the day, I think everything that I do, everything that we do is really geared towards trying to understand why Black people capable of pregnancy have the worst reproductive care access and outcomes of any racial and ethnic group, and how we can fix those things. So I'm so happy and honored to be in the presence of all of my fellow panelists today, and hopefully we can come up with some good solutions to move forward.
Thank you, Dr. Green. All right, so now that we've gotten the introductions out of the way, and again, I'm Crystal Tyler, she, her pronouns from Rhia Ventures. We are really thrilled to jump into this conversation. So what we'll do is, I think what we'll do is start with sort of the broader context setting to make sure that everybody's on the same page, and then we'll jump into solutions. We'll suggest some solutions to try to address this Black-white health gap. So Tiffany and I are going to start with some broader context. And I'll start with a little bit of history, and then we'll move to Tiffany to discuss some current policies. So from a big picture perspective on the historical context of racial inequities when it comes to healthcare, I'll actually start with a quote from Dr. Gail Wyatt that says, what happened on the auction block centuries ago is still unfinished business for African Americans today. I think that quote is still salient. And I'll say that the health of Black and Brown communities has really been compromised over time due to multiple experiences of racism, from slavery about 400 years ago all the way through to today, the post-civil rights era. So for example, I work in the reproductive and maternal health space, so I can use a reproductive health example of non-consensual gynecologic surgeries, including cesarean sections performed repeatedly without anesthesia. And this was done on Black and Brown communities to perfect medical procedures that primarily benefited other races. When we look at the economics, rape for economic purpose during slavery all the way through to Jim Crow. There were also and currently are unequal civil rights, and non-consensual medical experiments still continue. So from a healthcare perspective, I'd say that historical narratives about racial inferiority are typically coupled with a legacy of medical experimentation, and these things have really exacerbated healthcare inequities and racial disparities and all sorts of outcomes. So I will turn it over to Tiffany to discuss some of how current policies today affect disparities in health outcomes.
Thank you, Dr. Tyler. I think you gave a really great overview of how we came to be where we are today. In terms of contemporary policies, one of the things that we study in my research group and our collaborative is how structural racism impacts outcomes. And I think we think of structural racism, we think about racism as these one-on-one interactions. And sure, yes, they're important, but when we think about policy, think about how our neighborhoods are segregated. Segregation is a very deliberate attempt to segregate, to hoard resources that benefit one group over another. And when we look at the health and well-being of Black Americans, segregation, it's remarkable how when we look at all these measures of structural racism, segregation comes up over and over as a very powerful force to do that. And we know that practices such as redlining, we know that all kinds of features of the built environment were used to exclude Black people from resources. In terms of contemporary things that I study, one of the things that we're looking at is birth cost recovery in Wisconsin. Birth cost recovery is a program that holds unwed fathers liable for all or part of the Medicaid birthing cost. And we know because of systemic racism that Black people are less likely to be married and Black people are more likely to be on Medicaid. And that is one, and in Wisconsin, of course, we see that Black people are disproportionately subject to birth cost recovery. Those funds don't go to children, and it may likely hurt families. And there's so many policies like this that, as Eduardo Bonilla Silva says, you have all these policies that are racism without racist. And I think we need to think very broadly when we try to understand how policies disproportionately impact Black Americans when it comes to unemployment. When we even think about Medicaid expansion, we know that states where the opinions of the white populace matter more than those of Black and or Hispanic folks when it comes to expanding Medicaid. So literally every policy that you can think of, racial hierarchy is embedded in those policies. And importantly, what I want people to understand is that we have empirical evidence for this. This is not something that we're just making up. And so when we want to take an evidence-based approach to these partnerships, we have to understand reality. And that is that racism, whether deliberate or not, permeates every single policy that we have. And these policies ultimately affect people's health and well-being.
Thanks, Tiffany. So I'm going to turn it over to Barina to give us some sort of language around social determinants of health, what that term means. We hear about it a lot. So I'm curious to know from your perspective, Barina, what do we mean when we say social determinants of health, and how are social determinants of health different from or impacted by sort of the root causes of like racism, classism, sexism? So I'll turn it over to you, Barina.
I could unmute myself. Thank you so much. So yeah, just to break down social determinants of health, there are all those factors that are within our environment that make up how a person is living or existing in their world, right? So when we talk about social determinants of health, we're looking at employment, and vocational skills, we're looking at education, we're looking at family systems, and we're looking at housing, economics, healthcare, and the access to all of those different things. So each of these different areas of our lives impact each of us in different ways. And so if we think about who we are and how we exist, even in our own little bubbles and offices where we're sitting today, we can kind of give it a look at, okay, well, what has my education background been? What has been my access to education, and how has that impacted my ability to have the job that I have, to have the housing that I have, to have the healthcare that I have, right? And so what we know is that, as you guys were just discussing, structural racism has impacted those answers for many minority populations around the country. And so when we look at how do we address healthcare, we have to take these factors into consideration, because healthcare is not equal in our country. At the most basic level, we know that you either have private insurance or you don't, right? And so we understand that with private insurance, well, you get that through your employer, and how you have your employer, you have private insurance may be directly related to the educational opportunities that you had. And so if we trace those kind of patterns back, we understand that we have to kind of level that playing field a little bit. And when we see someone in our clinics and they walk in our door, we're not just seeing someone who may have a heart condition or, may have diabetes or whatever else is going on, that those are all directly related to all of the social determinants that exist in their lives. And unless we address each single piece of that puzzle, we are not going to be able to heal even just the basic medical pieces. So a concrete example of that is if you are an individual who doesn't have housing, who is living on the streets, and you have diabetes, let's say, your access to healthcare is limited. Where are you going? What clinics do you have access to? Then we have to consider, okay, well, if you're someone that needs to be taking insulin injections or measuring your blood sugar on a regular basis, do you have access to the tools, the money, cleanliness? Where are you doing that in a shelter? Where are you doing that on the street? All of these factors kind of impact, are you going to be able to manage your diabetes? Do you have access to healthy food? We know here in the District of Columbia, we have significant food deserts in Ward 7 and 8. And so we understand that people are looking at, okay, a bag of Cheetos, they don't have access to fresh fruits and vegetables. So managing even the diet part of diabetes becomes complicated. So when folks come into our clinics, we're really looking at what are all of these pieces and how do we address each piece of that puzzle to start advancing healthcare? So it's not just, we can no longer look at healthcare as an isolated, you have one condition, let me give you some medicine and it's better. But if you can't even get to the pharmacy, if you don't have the money for the pharmacy, insulin needs to be refrigerated in most cases. Where are you refrigerating it? These are all barriers to healthcare that we're looking at. And so the social determinants really impact your ability to care for your own health.
Thank you, Barina. So I'm going to shift gears a little bit and open up our discussion to the role of the private sector. So before I jump to Erica with my first question on this topic, I'll say that often responsibility for solving all of the world's issues, health inequities in particular, it's really placed at the feet of healthcare agencies or nonprofit organizations. And responsibility for funding these solutions is often placed at the feet of government organizations or taxpayers or philanthropy in the form of grants or subsidies, for example. But there is a role for private sector here. Because our audience might have differing levels of knowledge on the private sector, Erica, I'm going to turn it to you to give us some terminology when it comes to financing solutions in the private sector and how these different types of financing solutions can either complement our efforts to advance health equity or undermine our efforts to advance health equity.
Sure. Thanks, Crystal. And I think I'll just keep it as basic as I possibly can, just to talk a little bit about the types. And you mentioned a few with respect to grants in terms of the ways that capital can be used to support, to advance, or to actually get in the way of advancing health equity. So just the three main ways that this can move is through grants, through debt, or through equity. And the ways in which those resources or those levers are pushed can actually, or the way that investors can push those levers can actually do more to accelerate health equity in communities by making sure not only which instrument or which tool or approach they're using, but also how they're using it and the degree to which they are focused on impact and health equity outcomes or seeking return. And so when we talk about these different ways, basically we all know about debt. Everybody's got a little bit of that, either coming out of school or a mortgage or buying a car, whatever the case may be, or taking a vacation. But essentially when you're borrowing funds from investors for a fixed amount of time with a fixed return, then you have equity and or flexible return. That's a whole other story. But anyway, or we have equity capital, and that's when you're raising funds, and this is again in the private sector, where funds that are raised by a company are raised for an exchange of ownership rights back to investors. And with that, investors tend to expect a return of capital, right? Like they want to see that come back, having multiplied itself. And they carry benefits and advantages and disadvantages for each. But then you also have grants, which are just when you received a gift or resources that don't need to be paid back in any way. There's no expectation of return of capital. So there's like the three big sections that we're looking at, or tranches of the way that capital could be used. And so you can see the tendency for incentives to make sure health equity is at the center, right? So if you're in the grant giving space, you don't expect any return. So you're just, 100% focused on what's the impact of this resource. And in debt, it's not necessarily looking for a big return, but when there's an equity investment, that's where investors are looking for major returns. But that doesn't mean that you can't do both and with the emergence of impact investing over the last few decades, and even further evidence that prioritizing impact and return is possible. We're actually, I think, now seeing the opportunity for health equity really to be supported and accelerated, and companies to be incentivized to focus on it. So I'll stop right there for a second and let you get to your next question.
Thanks, Erica. So I am going to turn it over to Donna. I'm curious to know how NMSC has deployed financial resources to advance health equity.
Yeah. So the majority of my work at NMSC leverages the New Market Tax Credit Program. And so this tax credit program, it's a federal program and it allows us to leverage capital to support investments in projects, specifically in low-income census tracts, but it's structured in a way to help fill capital gaps and provide some catalytic capital to the project. So it gets to sit a little bit in between that debt and equity space and actually provide some capital to the project that it otherwise wouldn't be able to receive. So as mentioned earlier, healthcare access, racial equity are both impact mandates for us. And Rhia did a great job of explaining that to address health equity, there's a larger pool of investments, there's a larger approach that you can make. And so we focus on a holistic community development approach with a priority on community-led and supported investments, meaning that in some communities, we're really looking at supporting a federally qualified healthcare center or a safety net hospital, which might be the right strategy for addressing health. But we hear from other communities that it might not be that direct healthcare services, but instead a mixed use project that might include affordable housing, or a grocery store, or an autism services nonprofit focused on early diagnosis and treatment. And so we do try to adhere to one of the recommendations that's actually outlined in the paper, is really thinking about allowing the community to define their own challenge and propose the solution, and then to address the key needs and to fund those solutions. And so while we're evaluating projects, we're asking the project, what is the challenge that you're having in the community, and how could this investment help you address that challenge? And then we're getting, really specific. We're diving down into, what are the key metrics that you're looking at? And when we do this, we're prioritizing projects that are serving communities of color and are led by people of color. And so a couple of specific examples I'll give. One of them is actually in correlation to some of the work that Rhia has done. Some was financed through what was called our Healthy Futures Fund program. And so this was an investment strategy that combined new market tax credits with foundation and community lenders, and was specifically focused on supporting co-location of healthcare services with community and social services or community assets. And so really thinking about bringing those two things together in the physical space to support individuals. We also just closed on our first investment in a new fund called the Equitable Health Fund. And this is a partnership with United Healthcare, which provides investment in a capital project. So this first project was the expansion of a nonprofit safety nets emergency room, psychiatric services, and cardiac lab. And this was in a hospital in a medically underserved community. And along with that investment in the physical expansion, the fund was able to provide a grant to their diabetes center of excellence. So the example here really highlights that the hospital had identified overcrowding and overutilization of their emergency department as a challenge. And through the fund, we were able to provide some capital to help them support that physical expansion, but also provide the grant resources to expand their diabetes prevention program or diabetes program management program, because the program is proven to reduce the use of the ED by their diabetic patients. So really coming at that project through two different ways. The community that this is serving is 99% people of color, mainly Black and Latinx community, and the hospital staff itself reflects that community that they're serving. So this project is just one example, but I really wanted to talk about the types of structured finance that we can pull together to think about how do we really think about the capital use to help those organizations on the ground do what they do best, and how do we help fund those strategies that are coming and being lifted up from the ground and in the community. And then our goal is to then go full circle and evaluate the effectiveness of those programs to inform the next strategy or the next fund and the next investment strategy, so that we can continue to further to advance health equity.
Thanks so much, Donna. And I have to say, I really appreciate, I heard all sorts of bells going off in terms of some core tenets of advancing health equity. I love that you're centering and elevating community-led, community-driven, community-based solutions to issues that the community has identified are issues in their communities. Thank you for that. I'm next going to go to Rhia to see if you can tell us a little bit more about how your co-locating model and grant financing helps some achieve the success that you currently achieved.
Yes, this is a great question, and we are so appreciative to the Healthy Futures Fund for what they were able to do with us. And it's not an understatement to say that without the support and investment from them, that we would not have, we call it the Conway Center, but that we wouldn't have it as we do today. We simply would not have a co-location model. That project was originally, just a housing model, and as we started meeting with the community, started looking at what the needs were in the community, hearing from our current clients what was needed. We really saw that what was missing, was the healthcare space in general in those boards, but also just community center space, drug treatment, mental health services, right? We could go through the list. And so by partnering with Healthy Futures Fund, what we were able to do is actually utilize some of what would have just been housing space to house a clinic. And we would not have had that opportunity. It simply would not have existed. We would have just had a housing program, which is important. But what we know is that because we were able to co-locate those services, we are seeing a huge impact, not only on our residents who actually live in that building, right? Obviously, they have a huge, massive clinic right downstairs, right? Or around the corner, depending on where their housing is. But obviously, we see them utilizing that. We know that the majority of residents are going to that clinic, utilizing that, partnering with that clinic. And because it is so close, there's none of that avoidance of appointments, what have you. But it's not just that, we're also seeing the impact in the community. And so over the last, probably 4 years or so that we have been in operation in that space, what we're seeing is that more and more community members are coming in and accessing services and asking questions. And I think that that's where we're really starting to see the impact, is that folks in the community are saying, wait a second, if you guys have this, why aren't we doing it other spaces? Why has it taken everyone so long to figure out that if you put healthcare and drug treatment, right, all of these things in one place, that people will come and access them? And so we're seeing that. And interestingly enough, as we think about the social determinants of health, we talk about access to healthy food as being a huge impact on health equity. And we are seeing more and more people now start to ask us, okay, well, can you put in a grocery store? Do you have any food access here? Like, how can we get that, right? Because we can send them, again, using the diabetes example, we can say, okay, you need to eat healthier, but they still don't have access to the food. So that's just an example of kind of how that space works. But it really is not an understatement to say that we would not have been able to do that project. Our funding and the way that we are able to leverage funds is primarily for the housing sector through our government grants and financing and what have you, or by providing healthcare, right? So we get funding that way, but that space in between, which is really what we needed to be able to finish off this project, came from the Healthy Futures Fund. One of the other impacts that we're really seeing through this is, I think, I want to say it's both a good and a bad, and I don't know that that's quite the way to put it, but we are really seeing how the equity issue plays out in these neighborhoods and in these areas for folks that have the access versus those that don't. And so that has really heightened our awareness in terms of kind of to the point you made earlier, how do we leverage more of the community voice when we're giving services? How do we talk with our communities and say, okay, what is keeping you from accessing healthcare at a particular clinic or in a particular space? And also recognizing that actually the fastest growing service that we have in that neighborhood is actually our behavioral health clinic that we have. We have a special trauma clinic that is embedded in the primary care facility, and that is the most accessed service of every service that we have in there. It is the one that's most often referred to. It's the one with the longest wait list on a regular basis, because we're seeing how violence is continuing to impact health outcomes in that area. So even with housing, even with the primary care facilities, all of those things, we're still not making the strides we need to see. And that's the area we continue to see a need. And so we have started this trauma clinic and are working to embed that within the primary care so that we can provide more access to those services.
Thanks so much, Brina. And what I really hear you saying is that the care that you're providing, the system that you've set up, is really meeting the needs of the whole person. Individuals in the community have historical trauma, present trauma, so you're addressing that need. There's housing, there are housing needs, there are food needs. And so you're really setting up this person-centered, individual-centered, community-centered program that's providing all the needs that an individual has, as opposed to saying, well, sorry, we know that you have food insecurity, but we're just here to offer you diabetes meds. Like, because people don't really live their lives separate like that. They're whole people. So I appreciate you raising that solution.
They don't. And I would actually say that one of the biggest barriers we see to care on a regular basis is the minute we have to refer someone out, right? Because especially you lose them. When you're talking about mental health or you're talking about substance use, you have one moment. And when that person walks in the door, that is your moment. And so if we can't provide it, if we can't escort them to the next stop on the healing train, we're not going to get them. And so you know, to your point, having staff that are specifically trained in how to literally and physically escort someone from one provider to the next is the difference between someone getting care and not getting care. Even something as simple as having to cross the street could mean the end of someone seeking out services. And so we work really hard to make sure that we have staff trained, whether that's a phone call, a webinar, or actually physically walking them and making those introductions. And that has been a key component. Co-locating is great, but no one's going to do it. There's still a door in between, right? Your apartment and the healthcare facility. You have to walk out one door and go in the other. And people we found wouldn't do it just because it's there. It really was that needing that someone to help walk them to the next place, to provide that escort, to help build that trust.
So if I can jump in here, because I would say that that's a like a perfect mirror of the ways in which investors should be thinking about or can think about addressing health equity as well, right? So if you have multiple tools and multiple approaches that you can use, all of them will need to be activated intentionally and strategically to make sure resources are getting where they need to go in the way that they can be most useful to address the health equity needs and outcomes in communities. And so we heard a little bit about the actual tactics of making sure that that happens in the approach with respect to community engagement, with respect to seeking out what's the gap that needs to be addressed here. And so when we think instead of these buckets, like, oh, it's either a grant or an investment. But when we start to think about what's the need here, what type of capital is needed here, and how can we make sure that that's activated with intention, that's such an important approach to understand with respect to the ways in which investors in particular can actually have some influence and make sure we are centering health equity in the ways that capital is going to flow. So the way Barina was talking about this resource and how it's been structured to meet need, we've got to think about where capital is going, how it's moving, how we're making decisions similarly to make sure that it's flowing in a way that's actually meeting the need and making sure that we're aware of the different resources, the different ways that we can approach that. So it's, you can sometimes use a grant to build the capacity for the debt funding to come in and make sure that that can be repaid, or to make sure that the growth in this particular endeavor actually has the time to do what is necessary. So I just wanted to highlight that, like as you were talking, I was like, yep, absolutely. And that spectrum of approach with respect to impact can operate similarly.
I appreciate that. Thank you so much, Erica. And I think making this connection between this can happen in a public health and healthcare space and this can happen in an investing space is really helpful. So thank you. And since we've already started in on solutions, I'm going to turn it over to Tiffany to speak a little bit more on some solutions to advancing health equity or reducing the Black-white health disparity. So Tiffany, do you want to speak a little bit on ConnectRx?
I do. I was really excited about the policy element that just came up in what we said, but I'm going to skip that for now. I'm going to hold it for now and talk a little bit about ConnectRx. As I mentioned before, Wisconsin really has very disparate reproductive health outcomes, and the solution and what's so powerful about the Saving Our Babies initiative, it is grounded in actually going to Black people and asking them, why do you think we have these relatively high infant mortality rates? Why do you think we're experiencing these disparities? And part of that larger effort is the ConnectRx solution. ConnectRx is basically a coordination system that connects Black pregnant people with certain risk factors or social needs, such as intimate partner violence, stress, which of course is across the board, across all income and education levels, experiencing the risk of being unhoused, food insecurity. And it takes those people, and a community health worker is really an essential part of this, that connects that person and their families to resources available in the community. And many of these community-based providers are director services for Black, but not exclusively to Black people. And so not only that, every person that wants a doula is assigned a doula throughout this process. And we've heard stories filtering in so far about people that didn't have a job, were at risk of being unhoused, and they're able to connect all that. So I tell folks associated with this project, which full disclosure, I'll be evaluating, is that it feels like this isn't a birthing intervention. It feels like a housing intervention. It feels like a jobs intervention. And I think that is really key. And I think that's what we're hearing over and over from my fellow panelists. You cannot have a healthcare intervention. You have to have a whole person intervention. And that is what ConnectRx is doing. And I think another powerful element of this is not just the doula and the community health worker, but the fact that the doulas stay in touch with the families and support them after birth. We're placing so much emphasis on having doulas at the birth. And I have my challenges with that, like putting all the failures of the system on doulas to solve them. But they also support birthing people and their families after birth. And a lot of what we see with pregnancy-related deaths is after birth. It's not necessarily just in the hospital. And I think it's just really critical for families to have that support after birth. And that's something that in our modern world, we just don't have a lot of. And so I think this is just, I'm excited. I spent a lot of my career, staying at my computer saying, I'm just going to stay at my computer and not bother with any of this stuff. But I think to really make impact, to really make change, we have to go to communities. We have to ask them what they need. And systems have to be, and philanthropy and private investors have to be uncomfortable with being held accountable. You must be accountable to the communities that you serve, or you will not be as effective, because without accountability, there's no trust. And that is a critical part of these interventions actually working.
So we have a whole section on accountability. And so Tiffany, I'm going to come back to you on this accountability piece. Before we leave this kind of bucket of conversation around solutions, Erica, I want to take it to you to talk about the hybrid structure between Rhia Ventures and RH Capital, and how that's really leveraged to advance health equity, and how we can influence impact and measure impact with that.
Sure. So at Rhia Ventures, as I mentioned in the intro, we are a hybrid organization. So it's a 501c3 that owns a venture fund. And so the business of the venture fund is bringing innovation to market. And so there are focused investments on market rate return, companies that can bring market rate return, right? And that is the expectation. But because there's been so little investment in women's health, just actually shining a light on it and bringing resources into that market, you're going to have an impact, right? Just making sure that there's more available. And with our mission and with our structure, our decision-making is mission first. And while we expect market rate return, we also expect companies to again, have an impact, not only by bringing the innovation, but also thinking intentionally about who is dealing with the greatest disparities around some of those challenges or the problems that that innovation seeks to solve. And so at Rhia, as the C3, we can hold that work. We can hold the understanding of how to think about both process and outcome with respect to health equity, and help companies in our portfolio, but any company really that's operating in this space, actually start to develop product and organizationally around some of those principles for equity. And so it's actually unpacking and being very intentional about everything from acknowledgement with the stated commitment at some level, all the way through understanding access and affordability, and how that's being addressed, and all the things that would go on in between, when actually developing an approach that could be addressing outcomes for those who've been most marginalized from choice, from right, from the resources, from the information, and quite frankly, from the care, or and with respect to women's health and reproductive maternal health in particular. So we're always on the C3 side developing the support, the technical assistance in that regard, and thinking about this not as an on-off switch. It's not a binary, right? Like, this work is so deep and so intersectional and so complex that we need to see how people are making progress towards some of these ends. Because of course, there's always that expectation of return for the companies that are in our portfolio because of the particular way we're deploying capital, right? And so in that respect, we also think about our impact. And so what is the progress that we can see over time by what's our contribution to the ways in which companies are actually now moving in that direction. And so that's work also that we can hold at Rhia Ventures. And because we're C3, we're grant funded, we want this work to be available to the field. And so as these tools and resources continue to emerge, those are available in the broader field, because we want to see more investors, more companies, more nonprofits moving with intention as fast as possible, even at the, what is it? You can only move at the speed of trust, but being intentional and thinking about what are some of those features, the levers that we can actually support companies with moving that work forward. So we're thinking both about impact measurement and management, and that's accountability, right? Like, how accountable are we for the impact that we claim in the field, and that we want others to actually advance as well. And then also, what are the tools and resources that we're making available to ensure more people can achieve that impact also. So hopefully we're incentivizing movement on health equity by making sure all those things are available. And so our own structure, right, like the ways in which investors can support this work, either through philanthropic resources to the C3 or making investments directly in RH Capital, is again one of those ways that you can be very intentional about how to not only accelerate the innovation, but also ensure that equity is part of that work as well.
Thanks, Erica. And so since Erica spoke about accountability as well, I think we're ready to jump into this piece. And I'll say I see some questions coming in. Thank you so much. Keep the questions coming. We will get to question and answer in just a few minutes. But back to accountability, Tiffany, would you like to share, what does accountability mean? I've heard a lot of speak. Tell me what it means.
Ooh, well, we only have an hour and 15 minutes for this panel, but we can start here. One is being clear and transparent about how you're moving, right? So we talked about organizations expecting a rate of return. Hey, the problems that we're looking at are multi-generation. They're not going to just disappear overnight. Sometimes that intervention is going to take years to work, and that part is really important. Being clear about communities, about who is benefiting, who is not. Even thinking about community-based organizations. All community-based organizations don't have the same standing in the community. They all don't have the same intentions. And so when you put community organizations and act as if they're a monolith, that ignores really important inter-community dynamics. So it's really important, as the panelists have been talking about building relationships and trust in the community. And I think a really important part of accountability that I think a lot of organizations do not invest in is evaluation. Evaluation is usually a very small part of criteria when you're applying for grants, and organizations are like, okay, did you implement the project? But at this point, coming from someone who, is looking at everybody talking about the maternal mortality crisis, I'm like, we had a report on that in 1917. Right, isn't it? We've been here for a very long time. And I think accountability means, how are you investing are you investing these funds to look like you're investing funds? Or are you investing funds in projects that have a very high probability of success, and why? I think it's time for moonshot projects when it comes to reproductive equity. I'm kind of tired of the little, grants here and there, and for organizations to say, we're investing in this. Well, does it work? Have you built enough money into the funding announcement for people to evaluate that? Have you worked with community organizations that are doing the work, but don't necessarily have the administrative infrastructure to support that work? Are you investing in data sharing and other things so that you can assess and constantly evaluate what if the interventions that you're doing are working? Because I keep seeing a lot of investments in small projects here and there that don't fundamentally reshape our structural environment. And if you keep investing in these individual level interventions to change behavior, in my case, change the behavior of pregnant people, we ignore these systemic issues that we need to fully flesh out and address. So accountability, again, I could talk about that all day, but those are just a few of my initial thoughts.
I appreciate that, turning the lens of accountability onto the funders and the investors to say that you all have some accountability here as well. And I feel like, Donna, this absolutely perfectly tees you up to discuss how you incorporate community voices and perspectives when identifying projects to invest in, and how that relates to accountability.
Yeah, no, couldn't agree more about the tee up. So thank you. But at NMSC, one of the things that we're really lucky to have is the LISC local office program and the LISC model. And so just to explain that a little bit, so LISC has 38 program offices plus a national rural footprint, with over hundreds of staff of people who are working in the communities, are involved in some of the planning initiatives and some of the task force, are meeting the community organizations, are vetting the community organizations, right? So when we are looking to invest in a project in one of those communities, the local office can tell us, is that community organization well received? What is their, what do they look like? How do they show up in an organization? Is this project something that is truly supported, right? It's very easy for somebody to submit something that looks wonderful on paper, right? But, we want to understand kind of, how does this organization relate to the community? And then some of it is actually, is this project the right project for the community? When it's, when you look on a map, there are oftentimes like this health center might look at like a great access point, but there could be cultural or geographic things that separate that access point from the community it aims to serve. Or there could be reasons why the community is uncomfortable living in the new building that they're proposing, right? That in the investment. So we leverage that local office staff to make sure that we're really validating the information on the ground and in the community. At the same time, we have a really robust intake form. So we are asking questions around not only the services they're providing and who might be receiving those services and how do they know that, but then also who's on your staff, right? And who's on your staff at different levels, right? It doesn't matter if your overall employment is one way, but your leadership looks different, right? And so we're asking a lot of those questions as well in our conversations with them. And then if there's something that looks like, an area where they could grow, we can sometimes leverage the local office to see if there are ways that there are connections or partnerships that could be made or resources that could be made for them to do that. Or is there a way for us to incentivize it or measure it on an ongoing basis? So one of the other tools related to accountability in the new market tax credit space that we have at our disposal is the community benefits agreement. And so every transaction that we close has a community benefits agreement. And that can be used as just a pure reporting, right? You said you were going to serve this many people or increase this many visits or employ this many people. And it could be used as purely like annually, just give us an update, or as we continue to build out a more robust IMM infrastructure, we can start having those conversations of why are you not hitting the targets? Is it a resource thing? Is it a community thing? Did you overshoot in the beginning? And what are there, if there's anything that we can do to approach that, or do we need to learn, right, for the next investment that the numbers, the projections that are given to us at closing might not be realistic, because we have a whole portfolio that can tell us what might make more sense and based on the project. So we continue to evolve. We continue to leverage on our local office staff, who are people who live in the community and are engaged in the community. And that really allows us to elevate projects, not invest in projects, identify those that might be not a great fit. And then also think about, what is that post-close continual process with that investment, and how can we better enhance the impacts?
Thanks, Donna. And so I heard you speak a little bit about using community voice to screen potential investments and projects. The last question before we jump to our question and answer session, I'll pose to you, Erica, and I'll combine it with one of the questions in the question and answer box. So flag, if you have questions, put them in the box. This is really around things that you can use, or frameworks that you can use to screen potential investments. We heard Donna mention community voice, use community voice to share, to screen potential investments and see how that would benefit health equity. But Erica, do you have examples of other tools that you can use to screen potential investments? And I want to tag in this question here from Brian on addressing market rate returns and affordability when you're thinking about screening, because we all know that folks are screening for market rate returns, especially in venture, but can we screen for other things like affordability or racial equity? And do you have any frameworks to do that?
Yes, all of the above. I think we can, right? So I'll start with framework. So in addition to being CEO of Rhia Ventures, I was the founder of the Racial Equity Asset Lab, and had developed a framework for decision-making, for investment decision-making, to understand how you advance a racial equity lens in that work. And so after years of doing advocacy work, but also working in institutional asset management briefly, I started to understand and see the patterns over and over again, and even some of the barriers to moving the work forward a little bit differently. And so I mentioned this being both process and outcome. You really do have to think about the things that you do on a regular basis, because if we're not intentional about that equity lens, you will absolutely perpetuate, reinforce the accumulation of advantage and disadvantage certainly along the lines of race in this country. Like, it is built into the system. And so to not be intentional doesn't mean that you want to see racialized outcomes continue or disparate outcomes to continue. You are just actually continuing a pattern of decision making that has brought us to where we are. And so to undo, or at least to mitigate that, you have to think about all the things that are happening in your decision making, everything from that stakeholder engagement. We've talked a lot about community voice, but data. Like, do you have relevant data? Data talked about like who's in charge, but who's actually being served, and thinking about getting some of that in alignment. What is your North Star? Do you understand why you're doing this work and the degree to which you're doing this work? So the real framework was actually created and designed to actually pull that apart and really take a deep dive on that decision making, that process. So it includes the accountability, the policy. What is the documented decision making that's happening day in and day out? Do you understand the system that is in operation and your role in a smaller ecosystem, right? So it's all of these different features that can help with some of that decision making. So it's a framework that certainly at Rhia Ventures, we're developing for reproductive and maternal health equity, so that we can make those decision points more available for folks to think about, right? Like, really to reflect on how are we moving along this potential spectrum, this continuum. With respect to what was the question on
Market rate returns, affordability to end users.
Right. So I think this goes to what your intention is as an investor. What is the particular approach that you're using? And so if market rate return is the expectation, obviously being very real about that, but then again, digging into that decision making to understand what is it and we can do, right? Like, it does it have to be one or the other? And I would argue it can be both, as you seek to make those investments, and making sure, like, what are the strategies and what are you incentivizing even a company or project to do with the way that you're structuring financing, and bringing other partners to the table as well. And so I don't think it's an easy one-time solution. It really is thinking holistically about what is it that we're trying to get accomplished, who else needs to be a part of this, what are the again, the tools, the resources that we're pushing into this process, into this project, or to this idea. So it's the intention that has to be there. It's not going to happen without some extra work, and also thinking about some of those features that I mentioned earlier.
Thanks, Erica. We have a few questions in the chat and a few questions from earlier. I'm actually going to ask Nzinga to come back on camera because I have a question for you as well. But before we get to Nzinga's question, I'm curious to know, there's actually a question in here from before the webinar. I'm going to send this question to you, Donna. It's on successful models for collaboration between private investors, nonprofits, and government to advance health equity. Do you have examples of successful models for collaboration with those groups?
Yeah, I think one really good example is the Healthy Futures Fund, because it brought together the foundation support, the government new market tax credit program, and some private capital. We are evaluating that project and the co-location model to really understand, now that we're 7 years from deploying most of those investments, to look back at what that looks like. But I think that there's a lot of evidence there that helps. I think one of the things that, to Erica's points earlier, is thinking about kind of how do you use all the tools in the toolkit from a capital perspective. And so when you think about all of the interested players in health equity, right, there are some government resources, there are philanthropic resources, there is private debt, there is community development capital or impact investment capital, and thinking about how to structure those in a way where you can leverage one from the other or fill different needs to support the same end goal, and really kind of align those, is where I think the North Star is. And I think that there's work that we can do from a fund structuring perspective that other colleagues of ours and players can do, but it really kind of takes that intention of thinking about what are all the capital tools and how can we use them together.
Yeah, thank you. And so this question is for you, Nzinga, and I heard Tiffany mention this also. Rhia, you might have some insight on this, so I will open this up to all of you. And it's building on the paper, Nzinga, and it's really asking about the resistance to generating evidence on the effectiveness of proposed solutions. So we know, and we've heard on this call, that improvements in health outcomes can take time and evaluations can be costly. So what do you say to investors and innovators who are reluctant to spend the money to evaluate some of the solutions that they've funded, or spend money to evaluate or assess impact?
Yes, thanks for the question. And I think Tiffany did an amazing job in answering the importance of us generating evidence. I mean, I don't think I can top that. I do understand the concern that we have when we start pushing for evaluations, particularly in the impact investing space, where there is this expectation for financial return. Right? I think there's less resistance on the nonprofit side, right, because it does help with their fundraising. And I think also we should recognize the challenges that innovators face when they're constantly getting turned down for their funding because there's a lack of evidence of impact, right? And the paper does briefly kind of talk on those challenges and why it's important. And so for me, I kind of come at it a slightly different way than the way Tiffany had articulated in terms of the accountability to the community, where I say that first, financial resources are scarce, right? And we should not be pumping scarce resources into interventions with no evidence of impact and no effort to actually measure the impact, right? I mean, a lot of this stuff has been going on for decades. These interventions have been in place for decades, and we can't speak to the actual impact that they're having. And then secondly, I would say that it is possible to assess impact and effectiveness of an intervention that does not require a rigorous impact evaluation. And I think Donna really touched on this in terms of how you can have a strong IMM framework where you can still monitor progress of the outcomes that your intervention is meant to address, right, over time. And I think as investors, we should be invested in our investments in the interventions, not just to brag about us making the investment, but over time so that we can talk about the impact that we're having, even if the outcomes that we're talking about are intermediate outcomes, right? We should be able to track something and say something. And so I'll just briefly go through some advice or some steps in terms of what both impact investors and innovators should be thinking about when they're building or thinking about their impact measurement system. So the first thing is just develop a credible theory of change that explains how the intervention is addressing a root cause of the health outcome being targeted. And then identify impact performance indicators that include outputs like number of clients served and health outcomes. It is not sufficient to just talk about the number of people served or the number of Black people served. We can't stop there. We got to track some health outcomes as well. And we want to track those, the performance of those impact performance indicators over time, making adjustments to the innovation and or the implementation as needed based on our learnings. And I think Donna touched on that as well. And then finally, what I would say is that we have these statistics that exist on what the status quo is, right? And we should be testing the outcomes from our interventions against the status quo, right? And this doesn't require a rigorous impact evaluation, right? We're collecting information on outcomes, and if our outcomes are better than the status quo, we might be able to say something about effectiveness. So that'll kind of be the case that I'll make for the importance of generating evidence, as well as it being feasible and not as burdensome on both the innovator and the impact investor.
Thanks, Nzinga. All right, Verena, I'm coming to you with this next question. Can you tell us what are some significant gaps in digital health access and utilization that impact inequities in health outcomes? Digital health is booming, especially unfortunately post-COVID. So what are some gaps in digital health access and utilization?
Yeah, this is a great question because we see that gap as you said, digital health is booming. As it's booming, that gap is increasing dramatically from populations that are able to access and engage in the digital healthcare space and populations that are not. So I think with most of us, as COVID hit, we all understood that every provider was doing that scramble of like, how do we pivot immediately to the digital health space, and what does that mean? And so, everyone's doing that a little blindly, but there's some really significant barriers that have to be addressed when we're looking at that. And from our space and our lens of operating an FQHC and operating housing providers, we were looking at folks who are homeless, who are living in shelters, who are living on the street. These are the most marginalized folks in our cities. And we could say, oh, great, we'll just have them do telehealth, right? Well, telehealth, obviously we need the devices. Let's just start with the basic barrier, right? You need a cell phone, you need a computer, what have you. You'll need internet access. You'll need a quiet place to be. We already know that right there kind of took care of any access for the majority of our population. But when we started digging even further into this, okay, let's say we can address this. We've seen lots of solutions here in DC, but I think around the country, where they said, okay, let's give everyone cell phones, right? We'll give everyone like a prepaid, easy access cell phone. One of the things that we quickly understood with our population is that even if they have the devices, we have a tech literacy issue, tech education issue, but that was not the primary issue. The primary issue was that in order to access most telehealth platforms, you have to have an email address or a phone number, right? So you sign up and then they send you a link through one of those two things. What we found is that even if people had devices, they didn't have a phone number or an email address, or more importantly, they didn't have the trust to provide those to organizations for care. And so we saw a lot of people saying, I'm not giving you that. I don't want you to know that. And that's just true with our population in general. And so one of the things that we really looked at is how do you provide access to care in a way that just eliminates all of those barriers? And what we were able to do is build out a telehealth platform that allowed for a waiting room, a virtual waiting room. And so that folks could literally just click on a link and automatically be in a waiting room, just as if you walked into the building, and a provider would just pick you up right from there, triage what's going on, who do you need to be sent to meet your needs. This kind of eliminated that you need a link, you need, a phone number, an email address, or what have you. The second piece is then accessing the actual physical infrastructure. We know through, at least in DC, that the provision of cell phones was not effective in linking people to care for many number of reasons. What we did instead is essentially set up kiosks or telephone booths around the community, in which folks could go into a little booth. There were instructions, but there was also staff members available staffing those that could help you link to your provider, either with us or any community provider of your choice, could help you navigate that. It generated, if you had to do the link-based piece, we had kind of a generic email so that anyone could provide that email, and it would send them the link and they could link on. So we were able to put that in some of our programs and services and our partner organizations with these populations, so that they were able to access healthcare kind of around the city in a way that was much more accessible and kind of eliminated some of those barriers. Also developing out tech literacy curriculums, ways to reach these populations in a kind of more creative fashion, and then some of it was also just accepting that even with COVID, people need people. And so things like outreach and street medicine just still have to happen. There's only so much in terms of the digital health space that we can do. At the end of the day, sometimes we just need people. And so we still had to continue to provide that service, but do it in a way that bridged those gaps or slowly built trust with people, so that maybe for the first 5 sessions, they weren't willing to do the digital, but then maybe we can get them to that space, teaching them how to do it. And then the last piece I'd say, and this is something that we are really working with, I know folks around the country are working with, is that a lot of our folks, there's a big difference between the audio and the visual when you talk about the digital healthcare provision. And what we found is that a lot of our clients were not comfortable with the visual portion, so doing an on-screen sort of thing for any number of reasons. But when you think about your home environment, where you're at, what vulnerabilities people might have that can be shown on screen, we found that a lot of folks were much more comfortable doing audio only. And so looking at how do we create policies, reimbursements, advocacy to keep audio only, because that really increased. We saw a 300% increase in people accessing services when they were able to do it through digital means that were accessible to them. And the majority of those chose the audio only. And so we need to be really mindful about how and why that is, and then how to create spaces for that to continue.
Thanks, Verena. And looking at the time, we have 1 minute left, so I'm going to squeeze in one last really quick question for anybody. So there have been a number of funds that have launched to bridge racial health gaps for communities. I'm curious to know if anyone on this call knows of coalitions of any kind that funds could join to mobilize resources for greater impact, or any coalitions or groups that have additional resources if folks want to learn more on these topics.
So not necessarily in the health equity space, but organizations like Impact Capital Managers, which focuses on private investment with an impact thesis, are organized to support generally private investment in this space, or again, just generally. And so I think actually, as I was reading some of the questions, I was like, oh, that's a good idea. That's a great next step. And having communities of practice is actually really important for moving this work forward, and a key feature of the framework, and whether or not that exists around a concept or sort of a sector or the thought leadership that is going to be needed for significant change. So I will just say I'm not aware specifically of one in health equity, but am aware of at the level of impact thesis on private investment. Impact Frontiers is another cohort based, or they do cohort based programming around investment. So I know there's the CDFI cohort that was focused on racial equity, and NMSC was a part of that. But in terms of like specifically related to health equity, I'm not aware of one right now.
Thank you, Erica. And thank you so much to all of our speakers. This has been incredibly informative. I've learned a lot. I'm going to turn it over to Nzinga to close us out.
Yes, thank you. And so I know we're about to be over time. I just wanted to put up on the screen the 4 recommendations of the paper. Wanted to bring it back to the paper. I'm not going to go over the 4 recommendations because I think they were heavily mentioned throughout the panel discussion, which was an amazing panel discussion. I thought the panelists did an amazing job of really highlighting the positive, the optimism, the potential for us to address health equity and a topic that can be very, very depressing. So thank you for the panelists. The one recommendation that I do want to highlight here is diversifying the pool of decision makers. And you know, we've talked a little bit about the accountability. I want to also make sure that I call out some of the work being done by our colleagues at Common Future, who recently completed a participatory investing action lab program that brought together philanthropic investors to build more intentional participatory practices into their work, specifically to invest in BIPOC-led health and economic justice initiatives. And so in the follow-up email, there will be a link to the work that they're doing. They partnered with our colleagues at Build Healthy Places Network and Shift Health Accelerator to create a national network of community advisors and identify leaders for sourcing community-driven projects. And what I want to mention is that they are now working on a toolkit that will be released later this month to support other investors interested in pursuing participatory community-led investing. So I encourage those of you that are interested in this to be on the lookout for this toolkit. And finally, I just want to say thank you again. Thank you, the panelists. Crystal, you did an amazing job moderating the session. And just a reminder, there will be a recording of the webinar that will be provided to all the registrants and a follow-up email. And it will also include all the links to the websites and resources that you heard during the webinar. So thank you. Thanks, everyone.